The latest statistics in 2017 estimate that 50 million people worldwide are diagnosed with dementia. Each year, that number grows by another 10 million. Dementia affects the neurological, behavioral, psychological, physical, economical, and social aspects not only of the diagnosed, but also the people who care for those beset with the declining symptoms of dementia. As our population continues to age, posing a greater risk for dementia, recent research and care plans have been developed to facilitate better care. It is my hope to alleviate some of the worry, fear, and unknown for those currently affected by dementia and those who will be affected by the most dreaded diagnosis faced by adults. Apathy, agitation, aggression, and resistance to care are behavioral and psychological symptoms experienced by almost all people diagnosed with dementia. These BPSD symptoms are heightened and intensified as patients enter unfamiliar acute care settings, residential care facilities, day programs, and even within the once familiar settings of the home that now seem foreign to them. The levels of stress experienced among patients, hospital personnel, acute care personnel, behavioral health providers, residential care staff, and family members amplifies the symptoms for dementia patients. It poses a risk for harm to the patient and those who interact with them. Aggravated symptoms increase hospitalization stays, disrupts therapy, and increases the likelihood of further complications. The primary way of treating psychological and behavioral symptoms of dementia to date has been mainly through pharmacological management. The primary medicines used are antipsychotics, benzodiazepines, mood stabilizers, and antidepressants. But these medicines, although sometimes needed, have not been approved by the Federal Drug Association for specific treatment for dementia symptoms. They're considered chemical restraints, have troublesome side effects, cause increased risks for the patients, are prescribed carelessly, and are often used in excess. Over the past 7 years, there's been great strides in training and in the application of non-pharmacological management practices when interacting with those afflicted with the symptoms of dementia. One program is DICE, D-I-C-E. This model expects practitioners to already understand the components that aid to BPSD. They then develop an interaction plan to address the behavioral concern. They describe the behavior, investigate possible causes for the behavior, create a plan of intervention to reduce BPSD, and lastly, they evaluate the effectiveness of the interventions and make modifications where needed. STAR, Staff Training and Assisted Living Residences, has been accomplished in 68 of the 1,341 community living centers within the Veterans Hospital Administration. They use methodical assessment based on science, multivariate intervention, staff training. They align the program in each community living center with the leadership goals of that particular institution. And then lastly, they evaluate and modify. The STAR VA program is the actual implementation within the community living centers. There they focus on behavioral analysis and care plan, personal preferences of the patient, and realistic expectations for that patient. Patient care. Patient care is analyzed based on individual behavior of each patient. The plan of care is intrapersonal activators, things within the patient's self that might trigger symptoms. Interpersonal activators, the relationship between the patient and the caregivers, which may trigger symptoms. And then environmental activators, like sounds, lights, even the arrangement of furniture. They assimilate likes of the client into the care and have favorable events which the client likes to be part of their care. they have realistic expectations based on the course of the disease for the patient. And they give voice to the patient through ameliorated verbal and nonverbal communication. They listen with respect, they comfort the patient, and then they redirect. Staff training within the STAR program focuses on skills in assessment, not assuming the staff is knowledgeable about the intrapersonal, interpersonal, and environmental activators. They conduct uniform training for each patient. So for everyone who comes in contact with that patient, they have a care plan of exactly how to interact with him. Collective development of patient behavioral plan. All practitioners assist in developing a behavioral plan together to meet the needs of that individual patient. They educate the entire staff to treat the patient according to the behavioral plan. And they take it from plan to practice by observing and modifying based on the reactions of the patient. They make changes where needed. The results speak for themselves. This is the data from 2013 and 2014 of the STAR VA program. In 2013, you can see the severity of the symptoms were at 3.1 before intervention, and after intervention, the severity of the symptoms was 1.1. 2013, the frequency in which these incidences happened was 3.9, and then after training and applying the program, they dropped to 1.8. The following year was an improvement. The severity was at 2.9 before intervention, and then after intervention, it dropped to 1.5. And the frequency in 2014 of symptoms occurring was 3.3 before intervention, and then after intervention, 2.1. You see the severity scale and the frequency scale on the side. The lessons learned from the STAR VA program was that the causes of BPSD is so multivariate that all professionals need to work together to assess interpersonal, intrapersonal, and environmental triggers for BPSD. Medical care facilities are in great need to incorporate behavioral health into their unique setting where they are posed to observe and discern patients during care, during teaching and coaching. They're also able to observe the interactions of family members and other practitioners as they work with the patient to see if there's any triggers there that those people might be unaware of. Nurses offer great insight into patient response and treatment and need to be incorporated into the program. And even first-line staff involvement, those who are in the office when patients check in, they're able to observe unnoticed the interactions that the patient has with a room full of people, with loud noises and different temperature settings and light settings. And lastly, but most importantly, leadership needs to be involved. Without the support of the leadership, new measures to implement behavioral analysis and assessments in medical facilities will not be possible. As you can see, these are things that would work not only in acute care, but across all levels of care with patients who suffer from dementia. Here are some other websites for resources for those who would like to dig deeper into dementia. The first one is the National Hospice and Palliative Care Organization with a link to their site. The Alzheimer's Association, as well as a link, and then the AARP resources for caregivers that they should know about. We thank you for your time and your attention, and Yolanda and I appreciate any positive or negative feedback that might help us do better in future presentations. Thank you very much.